A clinical process assigns a health state to every moment in a patient's life. The patient population is the collection of all individual trajectories simultaneously. A single patient history is one trajectory drawn from that population. It either crosses the critical threshold or it does not. Expected outcome across the population averages all trajectories simultaneously. These two objects are defined on different mathematical structures. Confusing them is the source of clinical survivorship bias. An absorbing clinical state is one the patient can never leave. Once entered, it holds permanently. Terminal organ failure is the prototype. The critical time is the first moment the patient enters that state. If the patient never reaches the absorbing state, the critical time is effectively infinite. Survival means the patient's critical time has not yet arrived, not that it has been permanently avoided. The clinical survival event at time t is the set of all patients who have not been absorbed. Conditioning on this event creates a new reference population. This new population assigns 0 probability to absorbed patient trajectories. All probability mass is redistributed among the surviving patients. The denominator is the survival probability, which shrinks as time progresses. This is not a correction for measurement error. It is a change of the patient population being studied. The unconditional expected outcome includes all patient trajectories in its average. Absorbed patients contribute their absorbing state value, dragging the mean downward. The conditional expected outcome excludes those patients entirely. Only the surviving patients contribute to the conditional average. The gap between the two grows over time. As more patients are absorbed, the conditional outcome becomes increasingly divorced from the full population. Conditioning on survival and observing long-run patient outcomes are two different operations. They do not produce the same result when applied in different orders. In a patient cohort with certain eventual deterioration, the conditioned clinical outcome rises over time. This is because conditioning selects patients who have survived longer. Those patients appear to be improving, but this apparent improvement is a selection effect. The underlying clinical dynamics have not changed. Conditioning on patient survival selects the low-hazard subpopulation of trajectories. Patients who survive longer tend to carry better baseline physiological states, so the conditional outcome is systematically above the unconditional population outcome. Conditioning on survival is a descriptive operation on the surviving subpopulation. It does not remove deterioration from the underlying clinical dynamics. Statistics computed on survivors apply only to survivors. They cannot be generalized to the full patient population. The divergence between conditional and unconditional outcome is the signal, not the noise.